Personally, I actually think that a single payer health system is probably the way to go. I am not in the majority in orthopedic surgeons. I if I'm a cross country ski racer. I've been to Europe a lot. My son has sort of liked the European systems. I think it's a little bit more logical and science to centralize and have some stuff organized as opposed to the hodgepodge system that we have. That said, I will tell you that most of my orthopedic colleagues are staunch Republicans, and it's why I have a hard time. I can't donate to any of the orthopedic PACs because they just want to keep filling that, but I'm not trying to be political. And I've thought about what I would say for you guys, and as an orthopedist, you're molded by your experience. My generation and certainly older, the orthopedic experience was, I would say a fairly dictatorial kind of program. We referred to our chairman as God. And I think most of the chairmen had a lot of power because it's been a field that had been well compensated. And in fact, in many of the teaching institutions, the orthopedic groups were private practice groups that had negotiated highly advantageous contracts with the universities, at least that I have experienced. Also, I think most folks in my generation probably did a pretty big portion of their training on every third or every other night call. And that experience does tend to lead you in my field with seeing lots and lots of folks that maybe have made some poor decisions, not taken responsibility for their actions, aren't even appreciative of time and effort that you might be doing to, put them back together. And so it is not uncommon to have a little bit of a, one of the sayings is it's patients like that that make people like me want to vote Republican, because you just kind of got a little frustrated with, I think, a feeling that people may present to the emergency room, feeling everything is owed to them and not understanding that, you may have had to pay for your education personally and, had to sweat a lot of time and effort in training. And indeed, most orthopedic surgeons, I think, like to have higher incomes. That probably pulls some people there. And in order to kind of be with the mean, it's a competitive field to get into, you tended to try and be competitive, and you sit there and say, well, the average person across the country is making this. And you end up having an elective schedule that fills a lot of the day, and then trauma on top of that. Most orthopedic surgeons make horrible spouses or partners because you spend so much time at night and the evening doing added trauma as in addition to your stuff during the day, that I was told, choose your work partners more carefully than your spouse. You're going to spend way more time with them than your spouse. And that was kind of the hard-ass, brutal reality of the people that are, now in power in a lot of the places. So that background, I think, biases most of my orthopedic colleagues to be much more conservative and less sympathetic to the kind of socialized medicine scheme that you might see perhaps in Vermont or in other areas. So that's kind of my personal belief and a little bit of what I see with my colleagues. I think the orthopedic PACs still kind of tries to have the, lobby against these surprise billing measures that don't allow you to balance bill or get, more than might just be accepted by a particular insurance or Medicaid or something else. So the, orthopedic society clearly is made to just try and protect its own, and that's what they tend to argue for on the political scale. I'm not sure if that got to the point of your question or not, but that was all I could think about last night when I was like, well, what are we going to say to these young kids to sort of make them understand where people are and where they come from?
Do you think that that is unique to orthopedics, or do you think that's shared amongst a lot of surgical specialties?
It may be a little bit more unique in orthopedics because orthopedics really is a bastion of a lot of old dinosaurs. It has had, I think, the least penetration by women, which I think give a lot more balance to a specialty when that's in there. I think, again, cardiology, orthopedics, certain subspecialties that have traditionally had very high RVU values for their work product and work ethic, are very competitive to get into. And so you get a kind of competitive, hard driving person there, as opposed to somebody that might be a little bit more sympathetic and humane going into some of the other fields. And again, I'm doing stereotypes. Trust me, there are some, beautiful orthopedic surgeons I've worked with, but there's also a lot of assholes too.
So with a single payer system, orthopedic or other surgical subspecialties salaries will probably go down. I don't know how significantly, but I think it's, the model right now that's unsustainable does benefit surgical specialties immensely. And I think with a different model, I think probably salaries will go down. Does that bother you at all? Or do you think that you're being compensated fairly? Or do you think that, you personally would be okay with having that caveat?
Well, it helped that I personally married a gal that had more money than I will probably make. So that said, it is a little biased. I grew up in poor rural Maine. I have guilt practicing in Vermont, making close to $500,000 when the average Vermonters are, trying to get by on 40 or 60,000 and really struggling. So I tend to look at where I am, where I've come from, and what other people around me, and say, I'm paid this because that is what, the salary they had to pay to recruit anybody else who works a hell of a lot less hard than I did. I've tended to stay at the hospital and, keep a full OR, keep a full schedule, work a lot of my, half day admin time and extra day in addition to call. I'd been in private practice for 20 years before I became employed. So you kind of build a work ethic. In order to do that, I was very fortunate. I have a wife who doesn't work. She was able to be a primary caregiver for our 3 kids and be there all the time. I am hence labeled Mr. Unreliable and Undependable for when anything with the kids happen, because I'm usually stuck at the office or the ER or the OR, and I feel like, well, I have to do that for my patients. It's a little hard spending so many hours feeling like you're doing service to your community to not, feel like you've earned a little bit of it. But other people work hard. I have friends that are linemen and they take call and they're working on these storms, plow guys that are, plowing the roads at night through all the hours. So, in reality, in this world, most people have rough jobs. A lot of people have call. You had to pay a little bit more to, take, 6 or 7 years of post-medical school education before you, really get in on your own and earn anything more than, resident salary. So I understand in the societal thing, you have to pay someone who's had to invest as much as I have more than someone who has invested less. Do I feel like I have to be paid lots more than a family doc or pediatrician or someone who has a little less hours, evening, night, surgery, lawsuit issues, things like that. Not a lot more. Do I think a little bit more is probably appropriate? Yes. Um, you know, in our particular practice, and I assume you would make any numbers that I divulge to you not be directly specific back to me. I mean, they cut my pay 60,000 last year because they had set it on the year before when one of my partners was on maternity leave for 3 months, and the other one had sort of moved to Massachusetts. The new one hadn't been recruited yet. So my traditional partner and I were working every other night for like a lot of the summer and into the fall. So we'd made a lot of RVU, and they go, oh, it went up, but then everyone came back and it went down, and they docked it appropriately. Um, you know, would I mean, I'm not sure my gut would say all doctors should be paid the same, because I feel like my hours in the hospital are a lot more than many of my colleagues. Some of that is a choice. Um, some of that is because I can. I had a senior partner who swore he made at least part of all of three kids' hockey games through their whole high school career. He had also spent 10 years of every other night on call, manning the ER, going in and doing everything. And his senior partner kind of, covered for him so he could make a little bit of the games because that was a priority for him. I have one kid that does collegiate sports and cross-country skiing like I did, and you don't really have to be there for every one of those races, and sometimes your kids don't even want you there anyway. So for rightly or wrongly, I have spent less time with my children because of the way the job is set up. With your generation, I think people are trying to have a much better balance and maybe trade off some of the income for a little bit more family time. And I think that's appropriate. But again, in answer to your question, yes, in a single payer system, I'd be paid less. And I actually think that's fair.
So I have a question about medical records. So one of the issues right now is that primary care docs are spending the majority of their time writing up notes instead of spending time with patients. The number I saw most recently was it was like 60% on the EMR, which is a pretty scary number as someone who's going to be a doc and probably work in, primary care or related field. That burden to orthopedics, what is that burden for you? And would you see any real benefit in that being reduced?
I cannot imagine any doctor known to man not saying there would be a benefit in reducing computer use and EMR use. I'm a dinosaur. I'm 57 years old. I had to have my son quickly get the Zoom thing on because it quit, it wasn't going. And so I am not super facile. That said, I go in with a patient, I'm talking with them, whether it's set for a 20-minute visit or 30-minute visit. And, I set up my phone, I have Power Mic Mobile, I set it on the desk, the mic on the bottom, and I say, I'm going to dictate your note in front of me. Correct me if I get any details wrong. Boom. Patient presents with 4-year history of carpal tunnel. It's gotten worse at night. She's tried splints, had a nerve study, had an injection, wished to go ahead with surgery, boom. And I just say everything right in front of them. So it is done when they leave. So I prefer to try and be done with all my dictations before I leave the hospital, and at least my home life is my home life. I have younger partners that, I got to be home now at 5 o'clock and I had to pick up our kids at daycare sometimes. They always scared them when I rolled in with bloody scrubs, grabbing the kid 5 minutes before, 5 seconds before the door closed, but I could do it. There are different systems. I'm a surgeon. I kind of like the absolute bare minimum, go straight for it. I am not the super cerebral, well, let me think of a 20-minute differential diagnosis and go for, all the zebras it could be. I'm usually thinking it's hoof beats, it's a horse. And, I give the patients, you're my mother, sister, brother, wife, whatever, this is what I do and why. And I I don't feel that the electronic record has to be a written piece of beauty. I have a best friend from college who he's on staff at Northwestern, and he says that he has to get all his notes signed within 48 hours, and they don't, his of the opinion, nobody ever reads them. They're all shit. You could say, totally bull anyway, and just click the thing and get the thing done. I feel like I'm not that bad. I like it to be noticeable, but I don't sit there and go back and proofread every little thing. Dragon Medical is pretty darn good, thank God. But there can be an occasional typo. Fortunately, I don't have to say acute angina and get it written as acute vagina all that often. But I think the current system is harder on the family docs because they're following up tons and tons of lab, particularly all this remote stuff. In our system, I think the patients are supposed to be 60%, Zoom visits and 40% in person for the family docs. They recommend for orthopedic surgeons, we have to kind of, examine the knee and the hip or the leg. We have to get an x-ray anyway. And so we're allowed to have, 80 or even up to 90% of our visits in person. Post-ops, you got to take out stitches and things. So that is much easier for me. I do understand it is a different kind of torture for a lot of the family docs. And, again, there is a little bit of a standard that a surgical note is often briefer than a medical note. I tend to focus on the orthopedic problems and, if they have AS or, something that's going to affect a surgical risk. If you have a 20 problem list, I also personally believe that 90% of our patients are on way too many medicines. All these drug companies, in my opinion, do a very limited study to say, okay, this can reduce your risk a tiny bit, but who knows when a person is on 8 different drugs or more, how all those interactions really affect it. And I think we tend to overtreat many things. I would prefer, to some extent, we went back to more episodic medicine than all of the prevention, seeing so many people on blood thinners and seeing all of the complications that I see because everybody in the world is on Eliquis now drives me a little mental, but that's kind of my own view.
One follow-up question, then I'll quit. So I understand. I guess the way I want to sort of reframe that question, because in primary care, because margins are so low, they are obligated to make these hyper-complex notes in order to get adequate billing, which leads to this enormous amount of time on EMR. So what I'm saying is that burden probably would be, so you answered my question, the burden of EMR would be somewhat reduced for you, but it'd be pretty marginal, where the insurance system as it stands today, which leads to the EMR notes, leads to the medical notes that we have, which primarily burden primary care. I'm wondering if your colleagues would be even aware of that, because it sounds like you didn't characterize it in the way that I just did, which I'm worried very few people realize outside of primary care.
Sure. I don't code above a 99213 unless I've been more than an hour in the room with the patient, and then I code a 99214. I'm an orthopedic surgeon. Every time I look at the examples, they always have complex medical issues, and every orthopedic one is a dumbass, simple, kind of thing. So again, in order not to sort of stray too far, I probably undercode some. And yes, I have some procedures that reimburse well, so maybe I can get away with that. The education on exact coding and how to maximize it or do it exactly within the rules is pretty complex. And as a practicing physician, sometimes you get really frustrated that the rules are so stupid that you're not going to always play game and do everyone. The most common example is, you have to have a H&P within 30 days in order to do any surgery or any procedure. And I know we've had GI docs that'll come in and say, fine, has to be updated. I'll update it. I don't care. I'm not going to listen to their heart and lungs. I'll just say they're fine. And, our administrator's like, oh my God, that's fraud. That's fraud. You're saying you're doing it. I was like, it's a stupid, stupid rule. This person is 50. They're perfectly healthy. They had their H&P with their family doc 35 days ago. And you're saying I have to do everything all new because of that 30-day rule in a person who's had no other medical events. I'm just going to say your rule is stupid and I'm going to cheat. So some people do that. And I don't, I listen to the heart and lungs. I actually am one of the few orthopedists who wears a stethoscope all day long. Every single pre-op patient, I listen to their heart and lungs. Am I a great cardiologist? No, but I can know an AS murmur. And I know that I'm not going to give my patient a spinal if they have AS, because I don't want them to friggin', drop their pressure on the table and have to do chest compressions. So I do listen to a heart and lungs. And so I say, oh, I've done my own H&P. And if it has been 35 days, I listen to it again. Do I take as long as a cardiologist? Half of them never listen to the heart anymore anyway. They just look at the goddamn echo. But I feel like those rules say you have to do something. They don't necessarily say you have to do it the best in the world. And if a reasonable doctor, listens to the belly and says, okay, it's not a rigid abdomen, I did a belly exam. It may not be what you've learned in medical school is a 12-point, check here, check here, check here. But I mean, I do know what an appendicitis looks like when someone has an acute abdomen. So I can say, belly soft, there's bowel sounds, that's my exam. So that's how I choose to do it, rightly or wrongly. And after 25 years of practice, I'm still not 100% sure whether, I should be going by the 1995 E&M code rules, the 2000, the exam where you do like the whole body exam and multiple things, or when you do the more problem focused where you need 12 points on each one and add your complex decision making. It used to be easier. If you got your own x-ray and you interpreted it, then you got the x-ray interpretation, you could make it from a 2 to a 3. So you knew at least as long as you had to look at an x-ray and interpret yourself while you're there in front of the patient, you didn't have to worry about, is this problem so simple it was just a 2. Again, I probably didn't answer your question completely, but that's the life I live, and I'll give you at least a window into that.
I had a question about your private practice. I was wondering if you could just tell us a little bit about it and whether or not, so I know now lately a lot of private practices are being increasingly owned by hospitals and larger corporations. I was wondering your thoughts on that and how your private practice has been able to stay private and independent.
Well, it isn't now. So, when I moved to Montpelier, Vermont, there were 3 other orthopedic surgeons, and they each all had their own solo practice. I had one, and then eventually my partner came, and we kind of shared an x-ray person, and we shared a business, but all of our wives were our business managers. My wife actually was my practice manager for the first, 5 or 7 years. And we would sit down, at 7 or 8 at night when the, kids in the car seat and kind of go over the bills and the ordering and, classic mom and pop shop. I don't know, maybe around 2000, we said, okay, this is kind of really inefficient. So let's become a corporation, S Corp, C Corp. We're one of the easier ones. I think an S Corp. And so, then all of a sudden it gets more tricky when you're having to make the decisions for your healthcare for your 15 employees. And you had to, decide, how much are you putting in for that? How are you doing your 401k or everything else? So we were in private practice, and, when I started making $150,000 a year compared to, 40 as a resident was like, great, this is fine. We kind of got it up a little over 200,000, which again, I felt I could have lived with indefinitely, relatively happy. To me, that's a lot of money. And, I was putting, you never actually got anywhere near that to spend because you're always trying to put your maximum away in your retirement. So there's like 40 grand gone. So you never quite had as much as you think you have to spend. That said, it was when we tried to hire a third person, and even at 300,000, you couldn't recruit anybody because all of the other places were paying more. You could not get anybody to come. That the hospital kind of gave us a guarantee, and we had that person for 3 years, which he had to be there to pay it off. And then he got paid more by another hospital across the way. And so the last part of that year, my partner and I, who'd been here for 10 years, were paying him more than we were. Then the hospital decided they asked, like, can we just recruit directly? And they had a guy who literally worked 1/4 as much as I did, and he was paid almost twice what I was. And we're like, well, why are we killing ourselves, agonizing every single year over trying to pinch a penny here or there on our healthcare system for our employees, when if we just, this guy got hired by the hospital and he's able to be paid more because they have some economy of scale. So we just said, all right, we were fiercely independent. And for years we'd say, we're never going to, have to bow down and work for somebody else. It's kind of nice holding up your pen and like, this is, I signed the paycheck, I'm the boss. I can decide, if I want to take a week of vacation now, as long as my partner would cover me. It was never like, oh, make sure you don't go over the 4 weeks. You only have, 21 days and you got to pay them ahead. And, you only get so many hours per day. And if the day we joined the hospital, there's like, I can't go on a vacation next week because, I haven't earned enough money here. And it was very much you're getting fit by the rules that they make for everybody else. And you're not really your own boss, which was a hard change for us. But we got paid enough money that we said, okay, this is what they're paying people working a lot less hard than we are, struggling a lot less. So we should just join it. And again, for the last year, I think I made the most money for anyone in the hospital. So I feel like they despite paying me more, they still are making more money by having me here than not having me here.
So just tag on question there. Did I hear you correctly that one of the main reasons that you changed from private practice to the hospital was because of the cost of healthcare for your employees?
Yes. Trying to pay for that and figure out where it was. And again, as a small group, we couldn't quite get the benefits that they have. And so we had to kind of go with the cheaper and cheaper plans. And we had my nurse of 20 years, she had a thrombocytopenic blood problem and had to, see some specialists and get transfusions. We had a number of older employees who were kind of sick and really were better served with the premium programs. And that was just kind of too hard to get it to do it. Again, for probably 5 years in a row, we saw our income go down to try and help protect our employees. And it was just like, all right, this is just getting too hard. And trying to, how much time you have to do to make each one of those decisions. There's a lot of decisions. And it is nicer now that the HR department can kind of do that. And most of our employees actually ended up getting more money. The nurses got much better income. The medical assists, the front desk, and all of those people had a drop in income. And in fact, one person, we kind of asked very strongly, can you, keep our people? And the hospital was absolutely not. We're your boss. We decide who works, who doesn't. This gal was paid too much, and we're going to cut her salary from, $18 an hour to $9 an hour. And she left. We lost a number of good people there, and it was hard.
So I want to ask about how do you feel about bundled payments or other models of reimbursement?
It is very difficult to be sure the accounting in the medical field is accurate. When we were in private practice, I could have a pretty good idea of what was coming in, what was going out. We made sure that if you had to use Synvisc or Orthovisc or a Hyalgan, which is a $500 injectable, that, the insurance was lined up ahead of time, and we, practiced in such a way to make sure nothing was kind of given away for free that we couldn't do it, or we just said, we can't do that service, or we don't have it. The hospital is like, we're going to do this. And for years, they kind of hired a guy part-time who worked in parallel with us. And I don't think they ever got his billing right. And it really kind of drove us crazy that they didn't really care if he got paid for the fewer surgeries he did. He did way less than we did, because he was ordering MRIs and X-rays and all these other ancillary stuff, which still made it a positive for the hospital having them employed. A bundled payment is a lot simpler. There is risk. Right now, the hospital bears a lot of the risk in, the complicated patient who stays longer, that has a lot more problems, they're probably going to lose a lot more money on. And so the hospital tries very hard to keep all of those payments up to pay for the things that aren't taking care of themselves, sometimes in the ER, or, self-pay patients, or some of the primary care and pediatric practices. The University of Vermont, I believe, had structured it such that their primary care docs actually carried their own weight with their RVU system. The Central Vermont Medical Center, in the poorer aspect of the center of the state, has always had to have a funds flow to the doctor side of the practice. However, in private practice, many of the family docs would do their own blood work, their own EKGs, things like that. The hospital said, you're going to send all the stuff to us. They get the facility fee. So the hospital does make more money that other people would be getting if they were in private practice themselves. And so they send that money back to the family docs or the primary care docs, in understanding that because it's a bit of a closed market and they're getting almost all of the services, ER, X-ray, echocardiograms, anything that gets done is sort of essentially done through the hospital. So I think the bundle system to me seems okay, but a hospital administrator could probably answer that question better than I can on how much stress is there on the budget. We, as a medical center, have lost money the last, I think, 3 years, despite some pretty drastic attempts at trying to balance the budget. But in a rural state with the pay that they have and what they need to do to recruit people here, it has been a problem. And, one of the hospitals went under in Vermont. They went bankrupt. So, as much as I'd say, oh, bundle payments are fine, if it causes the hospitals to close in small areas, then either you're a capitalist and you say, well, they died on the vine because they weren't successful enough, or you're like, these small communities need help. You can't just sit there and not have them have services. You can look at that either way.
Do you see Medicaid patients, or did you when you were in private practice?
Oh, yeah. I mean, I would never not see anybody for any reason. In fact, I would say we probably see fewer problem patients now than I were in private practice, because, all somebody has to do is make, oh, I'm going to come back here with a gun, and boom, they're like banned from the practice. Or if they threaten one of the nurses, the hospital policy is, they try and protect their employees. Whereas, I tend to think, okay, this is an uneducated guy. He's, got a hot temper, and they say a lot of stuff that they're not going to go through. Now, that said, we have had, shootings in Barre, Vermont, where, a caseworker was, shot in a courthouse in Barre from a, guy that was upset with something with his wife or family and kids. So I shouldn't be too naive. There are some people, a lot of guns in Vermont, and some of them could come in and shoot anybody on any given day. But I grew up relatively poor. My dad and mom paid for a lot of my medical school. I had loans and bills, but they paid for quite a bit. And he said, you are never going to not see anybody because of payment, because we paid this for you. And my partner felt the same way. So we never refused to see somebody for payment. If they didn't talk with us and, call back and answer and just totally, not answer the phone, we would send them to collections so they'd ruin their credit score so they couldn't go out and buy a snow machine the next winter. But no, well, we'd still, it's a small community. You're not going to not take care of anybody. We are the place of last resort. These folks with cars have no place to go without cars.
Sorry, with cars?
So Central Vermont Medical Center is, an hour from, Hanover or Burlington, Dartmouth or UVM. And,
without cars.
Yeah.
Oh, I see.
So there are a lot of patients that they just get by on the local transit. They're too poor to have a car, or they have a disability, or, they have a vision handicap. So we have a lot of patients that rely heavily on services. And, this is Vermont, it's not Texas. We actually provide the services for those folks. I'm sorry if any of you are from Texas.
Texas does have the highest rate of underinsurance and uninsurance.
So, good. So I'm mocking the correct state. Thank you.
Yes, you are.
I personally like to take digs at Texas. My dad sort of went down there toward the end, and God, I hated it every time I had to visit him. So
I love Texas. I lived in Texas for years, but did I understand your answer to my EMR question correctly? You understand where I'm going with that. I'm just kind of like, I
don't understand where you're going with it.
Okay, so the EMR question is, you don't spend a lot of time on EMR because you don't need to because of the way billing works in your specialty. But in primary care, there's just this gigantic amount of information that needs to go in the notes, because if it doesn't, then the practice doesn't make money. Because the complexity of the patient has to be present in the notes so that insurance bills more, yada, yada, yada. So there's this disproportionate burden put on primary care, where they end up spending 60% of their time doing the note outside the room, after work, at home. And that's an astonishing number. And so one of the things that's happening, that's part of why a majority of primary care physicians want a system of universal care, because the idea being, we don't have to deal with insurance. We don't have to do these crazy notes. We can spend more time with patients. And my suspicion is a lot of people don't know that it's not aware. And so that's why I brought up that question.
So I would differ a little bit. And again, I have to be careful because I'm maybe talking out my ass and something I don't truly know a lot about. I think that the primary care notes are not necessarily efficient, and they could touch on with bullet points enough issues to get a 99214 or 215 without having to spend as much time as they do doing it. Now, I may be biased. Maybe we have a more electronic record naive way. I see a lot of notes that are kind of boilerplate fill in to get the coding. Patient was examined, this is and this were done, positive findings are this. And you look at that and you say, okay, I know that the stuff that they actually specifically said, as opposed to the EMRs get better and better at trying to fill all this stuff in to make those coding barriers. And, right now in our emergency room, I think 80% of the note is totally bullshit. It is not helpful for the patient. It's not there. It is auto fill in by all these systems, or, they may ask a few questions going in, but I think many of our primary care docs could have notes like surgical specialists that would meet criteria and wouldn't be as long or hard to put in. I haven't walked a mile in their moccasins, so I may be wrong.
But I mean, say it's right. Say, all right. So right now it's 60. So say they are able to cut it down to 50, maybe even 40. that's, you know, a wildly different number from what you described, able to, you know, finish the note while you're still in the room with the patient. So I'm just so that reinforces to me, that reinforces my suspicion that people don't realize the burden that's happening in primary care. And one of the ways of correcting that would be increasing reimbursement for primary care, which means, because of the way reimbursement works, everybody else makes less because they have the most visits.
Or simplifying the coding requirements.
Which means changing the insurance system.
Right. I'm fine with changing the insurance system. I'm not sure the only way to do that would necessarily be single payer, although I think it's probably more logical for other reasons. But if you're just saying for the billing, I mean, some people say, oh, do them all by time, but then you get, you know, audited if you're doing too many notes by time as opposed to by point or bullet. But I do think the point bullet system required for electronic note billing is in and of itself inefficient. We surgeons like efficiency. We like to just like do what you need to, get rid of the fluff. And I think a lot of electronic medical notes have ridiculous, unnecessary fluff. I'm an orthopod. We're strong as an ox and half as smart. And, you know, we kind of focus very much just on the surgical doing. And again, I sort of believe a lot of these people might be able to get by with less medicines that we kind of push on folks that make it complex for other reasons. I'm giving you my biases, take it for what it's worth.
So this is kind of a loaded question. You kind of answered it earlier in a way, but do you feel like, on the whole, your profession serves the community as a priority and has profit second in mind, or do you feel like it's switched around due to the incentives?
Sure. That's an awfully big generalization to try and make. I would say that there are many, many people I've seen in my training and who I know who are really trying to serve the community and do the right thing. I don't actually see many people just trying to get money from medicine as opposed to really take care of the patients in the right way. Different people have different biases, you know. Yeah, you have a doc who's been sued and he'll, like, you know, be extremely defensive and practice in a certain way, or, you know, this guy say, I won't do any of that because they could put my name on the chart and I don't want my name on the chart. So people come at it in different ways. As much as, yes, I've known a lot of jerks in my training, I actually think 90% of the docs whom I've ever interacted with are pretty good people that are trying to do the right thing. Anytime somebody has something and you try and take it away, I think you kind of run into this feeling of entitlement. And I think my profession may feel a little entitled to this pretty generous pay scale that they've had. And, you know, I've always felt like it's easier to freeze that and bring the others up than to say, all right, we're just going to, you know, cut that in half so that no family doc is working beneath the 150,000 level or something like that. I think my profession would probably fight, balk, and, you know, squawk quite a bit as a group. And, you know, they're not all stupid. They have pretty good political connections with a lot of senators and the Washington political lobby things to kind of try and fight for their share of the bone. So I think as a group, our people will probably fight quite a bit to try and maintain their income. But, you know, the stuff I hear about in Florida where people like just fraudulently run through numbers or clinics or, you know, phone in pharmacies to just, you know, charge huge amounts of money for not doing care. I mean, the stuff that really sounds like fraud. I have seen very, very little of that, and none in Vermont. So I can't paint the brush that even some of the colleagues whom I might not think a lot of, I don't think they are thinking of their money first before their patients. They may think of their lifestyle a little bit. You know, they may feel like, well, you know, I've done so many hours of call, I should get paid this amount, and, you know, make some decisions that you could argue, you know, did they unbundle a little bit on that versus the other? But I think at least here, people recognize how friggin' fortunate. Most of my training was nobody's ever going to cry for an orthopedic surgeon, so shut your face and don't whine.
I guess kind of my question was like that. Do you find it difficult ever to prioritize the community, like focusing on your patient, or rather than focusing on the profits? Like, do you find that the RVUs that you put out are monitored or tracked, or are more important than taking care of your patient in the best way possible?
No, we accept the fact that all of us at my hospital don't even meet the median RVU earning for the orthopedic. You know, average orthopod's supposed to do, I don't know, 8,000 RVUs or something. I don't make that. I never will make it. My partner argues we shouldn't have that as a goal. You know, the university tries to say, well, you know, based on the median, you know, we expect you to be at least middle good. And he's like, is the median orthopod really spending enough time with their patients, or are they just breezing in, looking at the x-ray, breezing out, making their tech do the cast, making their PA do this, making somebody else do the note so they can whip in? And I mean, I looked at a residency where they saw 120 people on a day of clinic. You know, I'm lucky if I can see, you know, 14 to 18 right now. Before COVID, I think I could have a day 20 or 20 to 24, and I would feel very proud that, like, okay, you know, I managed to see enough people and feel like every single one of them could have been a member of my family, and I would have been okay with the service I provided. That it was, you know, fair and reasonable for, you know, I mean, nobody wants to spend their time in an office, a doctor's office. They're there because they got a friggin' problem. And I've always tried to fix it and get them out of healthcare as fast as possible so that they just, you know, I know there are big practices where they ping pong every patient to the foot guy, the shoulder guy, the knee guy. And, you know, they end up seeing like 12 different people for 12 problems. I still do a lot of generalist stuff. So, except spine. I'm not going to handle spine, but I will try and take care of all the stuff because, you know, they don't want to have to go to other visits. If you can do it, take care of them. And again, I may have missed, did I get all that question?
Yeah. Yeah.
Okay.
I'll let somebody else ask a question.
I guess I just had a question. Oh, sorry.
I was just saying, yeah.
Just like your overall satisfaction being an orthopedic surgeon. I know you guys have long hours and the burnout rate can be pretty high. So just wondering, you know, do you ever regret going into a specialty that is so demanding of you, or do you still feel like this was the right choice?
That's a great question. The vast majority of times, I love my job. You know, you get to be in the OR, crank the tunes, you know, you get that state of flow, you're doing stuff a lot, you know it. You get to use power tools, you know, you're problem solving, you're thinking in 3D. I could not imagine any other medical field being a tenth as rewarding as orthopedic surgery. And, you know, if I had to be a psychologist or even a family doc who had, you know, 60% of their panel with depression, I would probably blow my brains out. Or maybe take my little 1939 Piper Cub airplane and just fly it straight into the ground so my wife would get the death money. But there are times when it's like, oh, you know, you have sometimes when it wears you down a bit. There are times when I think, you sort of feel like there ought to be some note of appreciation for how hard you're working or how many hours. But then you're like, no, wait a minute. Other people have odd hours. I'm well reimbursed. And it is tricky because you have been well reimbursed that, you do have the potential to retire, potentially earlier. My senior partner, I think he stopped doing surgery at 55. He stayed on as a vice president, chief medical officer at the hospital, like for another 5 or 7 years. I don't think I could retire before 65 and feel like I was really, doing a decent amount of work. I think that'd be, again, I have some mixed psyche that I sort of hate rich people, but I sort of live the life of one now. So I have to kind of hate myself. But I kind of feel like I've done through all this training. Everybody else has to work at least till they're 65. I should work till I'm 65. Being 58, that starts coming close. You start wondering, well, do you do locums? Can you do something else? Or, are half retired docs just shitty docs and you shouldn't do that at all, either all in or all out? There's definitely people in both camps. My wife made me promise that when all the kids got into college and through it, if she wanted to move back to Seattle, I'd drop everything and go with her. Fortunately, there's enough traffic there that she kind of likes the less traffic in Vermont and Maine, and where we tend to spend more time. Although she likes the beach in Florida, where her mother has a little kind of condo from time to time too. I never regret going into orthopedics. I don't think I've regretted being in private practice, even though I probably could have made a lot more money if I'd gotten out a little sooner. I don't regret working for the hospital now because I worry a lot less about financial security. I look at my colleagues and I still think I have more fun than everybody else. Yes, I have to get up at 5 a.m. every day to train. I still try and cross-country ski race, and I'm too tired at the end of the day and it's too late. And, if I want to spend any time with family, the only time I can do something personal for me is pretty much, 5 to 6, whether it's roller skiing or biking or doing a strength workout or running or, mountain bike, something. I have to do it then. And, in Vermont with the winter, you're doing it with a headlight in the middle of the dark. But, for me, I like trying to stay physically fit. I still want to beat the guys in my age group as much as I can. Competition is sort of a big part of my life. For the last 3 years, even at my age group, there's only been one whole hospital employee out of the 1,400 people that can beat me in the annual 5K Corporate Cup Classic, that race that we have. So,
how fast do you run?
Well, lately they've only been 6:30s. It's fortunate that there's not a lot of competition. So no, I don't. I regret nothing. I have been blessed with an awesome family, both to be born into, great siblings, and I have wonderful children. My wife. I learned 3 things. I've told every medical student or resident who's ever gone through with us that we were told as chief residents by at our big, we had our visiting sage come talk, and he's like, three rules to a happy life. He goes, 1, you guys are all going to be orthopedic surgeons. You're going to love what you're going to do. Your patients will be nice. You'll have all this intellectual stimulation, at the hospital. So rule number 1, let your spouse choose where you live. And they're going to be like, you're going to be like, you want to go play in the mountains and the snow and the ski, which I did. He goes, but your spouse will be home, and they may, if they're not near friends or support, or they're not where they're happy, and they're only there because you are there, they're going to be unhappy and you're going to be unhappy. Rule number 2, stay married to spouse number 1. He goes, the biggest way you can frig up your life is to, go and start getting a wandering eye and end up with a divorce, and you're supporting 2 families. And then the money really does start to push, and, you may have wrong incentives for how you live your life. Rule number 3, if you want to borrow money for your house, fine, but every single other thing you buy in life, you have to pay cash. So don't go be getting a big boat or fancy RV or plane or whatever else toy just because you see all these other people having it. unless you can pay for it with cash, because otherwise you get on the bad end of the money curve and it's a problem. So I think you do have to try and keep your expenses down. I like to say my first year that I earned a paycheck was $12,000. No, it was $24,000 gross as an intern. And at the end of that year, I had $12,000 in the bank from that. But I pretty much lived on, leftover food on the trays from the patients in the hospital for the whole time that I was staying there. And you guys probably don't want to do that. That said, pay for toys in cash, let your spouse choose where you live, stay married to your spouse is the best advice I could give any young people, because I think it really has worked for me and all the successful physicians I've known.
So not to bring a sad note after that. That was very nice. But do you ever find yourself despairing about the healthcare system, the broader healthcare system, and kind of the disparities that exist within it?
No. Well, a little bit, because of the recent political tribalism going on in the country. If people start actually thinking that science and being smart is bad, I might. That said, I think anybody going to a doctor, there are people who are appreciative of nothing, but there will always be enough people appreciating that you're trying to do something personal for them, that it is hard to imagine selling gas stoves being anywhere near as rewarding as what we do. So I don't despair the satisfaction that can come from our profession. Asked, did I try and push any of my children into medicine? I didn't, because I think you really need to be motivated internally. And if you just, want to have a nice life and, try and have some of the toys I've had or some of the good experiences, I think it may be better not doing it, because I do see some people that struggle that don't get the reinforcement from just kind of seeing the people and take care of them. Do I despair about the money? No. Again, I think the kind of brutal lifestyle that your only life is in the hospital and all of your only identity is a doctor, you retire and you either don't know what to do, you go crazy, you get sick and die. And so it's not a healthy and happy balance. I think for your generation, working a little bit more like a normal person and not having it consume your whole life will be healthy and good. It may not be quite as well rewarded, but again, I kind of feel guilty that we've been a little bit over rewarded in general. The societal contract of, trying to do the right thing for your patient, irrespective of whether you get, paid a little higher or not. I mean, I really feel in Vermont that still exists and it's great. I worry some of the cities where healthcare is a business and people advertise more and they compete against each other. That may be less the case, and maybe I'm a little naive because I've been 20 years out of that now. But no, I would never regret what I've done. I don't think any of my 3 kids have seen the life that I have led and want to do it, and I'm okay with that.
Did you said you spent, you keep talking about all the time you spent in the hospital, so I'm assuming the answer is no, but were you involved in other types of, organizations or advocacy things or research, or was it mostly practice and that was all of your?
That is my Achilles heel. It's a small community. I'm a good cross-country skier. I probably should have been a lot more involved with a coach and teaching the young kids, and I'm a little selfish. I feel like almost all of what I have to give to the community is based in the time of staying at the hospital as long as I need to be sure that I've checked everything and the patients are taken care of the right way. That I've done a decent job trying to help my colleagues, particularly if they've got young kids or family issues. And I was not raised with a great deal of volunteerism, so that is not a wonderful part of me. I mean, I probably give selfishly to things that have touched me, but I don't. I have volunteered. I'm head of the M&M committee. I've been on medical exec. You can argue, is that self-serving, or are you trying to volunteer in the medical community? I have always stepped up and volunteered pretty much since I got here. But it's a small community. It's easy. I mean, there's not all that many people to go around. Do I volunteer at a church or other social organizations? I know Marvin has all sorts of things he does, and I don't. I haven't gone to the legislature to argue for all these things. I'm not that eloquent, and I'm not all that smart. So I just, I try and give the patients their money's worth and the best I can with my experience and help, and think of myself more, I think, as a blue collar laborer than, a businessman, board member, or CEO, or something like that.
And
one of my favorite cartoons is the Balloon County cartoon, where I think the writer Bertrand Breithaupt, who sort of had Steve Dallas as his character. The writer, I think, had an accident in Hawaii, broke a spine or something, had to have spine surgery. And he did this cartoon where he's lying on a hospital gurney, and this guy in a surgeon thing come in. So, broke your spine, eh? Well, don't you worry. We're going to get you back in there, excavate right down, show up all those processes, lay down some good old goddamn American steel, and make you straight as a board. And he turns to the reader and says, it's the blue collar aspect of orthopedic surgery that always makes me a little uncomfortable. And then he throws on a hard hat, nurse, get me a bud. So, I mean, I have a little bit of that. I identify a lot more with our blue collar, less affluent patients than the Stowe crowd.
Yeah. Are you worried about people who don't have health care in America? Is that?
I have never seen anybody not be cared for because they don't have health care. I have seen people not go to the dentist, I think, because they feel like they didn't have the money to go to the dentist. I feel like in the rural places I've been, the emergency rooms always provide the critical care somebody needs. I've seen all the babies get born, the obstetricians will take care of the babies. Maybe the high blood pressure isn't treated all that much, but I'm still not sure if my pressure ever went high, I'd put myself on an antihypertensive anyway. So I have a hard time feeling like tons of people aren't getting care. When I was in Seattle, all the drunks in Pioneer Square, they got, Harborview, we took care of everybody. So I haven't seen a lot of direct effects of people not getting care if they felt they needed to get it. I do understand that people choose perhaps not to get things financially, and that's why I think in general a universal system would probably be better. And I think as a country we are wealthy enough to do it, but with the friggin' morons we have in the Senate and the White House right now, I despair.
For me, my line of questioning, just to give some context, is I'm interested in surgery as well, and I'm hoping to do it. But I would like to be involved in advocacy as well. Do you see other surgeons in that area and work on?
Atul Gawande.
Yeah. Very aware of him. Yes. Yeah. No, definitely.
So I mean, it's hard. You have to make it a priority. I got into private practice at age 33, and we started popping out kids, and I was a mom and pop business. So, and, I didn't really grow up with a kind of family that thought big like that. So I did not make time for it. Um, the, I don't know if the people that self-choose, community private practice as opposed to academic practice maybe have a different mindset. I mean, I've never had an intern. I always, every single distal radius, I go in and set it. In some respects, I don't always feel like I ever fully grew up, and that I still do my own scut work in that respect, going into the hospital a lot at night. I think the people that I've seen do more advocacy, political work, whatever else, have tended to be more in the academic world. So if that was important to you, you might not want to go to a small town of 8,000 people to be a surgical specialist. Now, our hospital actually serves about 40,000. We're not just the town of Montpelier, but you guys are familiar with Vermont, right? Are you guys Vermont students, or we're all over? No. So you may not have known any of these towns I talked about, except Seattle. All right.
Thank you. I appreciate it.
I know Montpelier and Burlington and Fairleigh and lots of little spots.
And it's not to say that I have some family practice colleagues that go down and speak to the State House quite a bit and do some great advocacy. John Matthew at the Health Center, my God, he goes down to Guatemala every year and does a lot of work there. A lot of the surgeons often actually tend to fly to the third world for a week or two and be on some of those programs, because it's just a straight carve out time commitment, and it's maybe a little less intrusive on your schedule going, long term. But I think the medical field is a wonderful field. You can actually branch out and do a lot of different things. And nowadays, I think, with job share and other ways of doing it, you don't have to be a full-time FTE or not. You can be a part-time and, potentially do things. You can create a lot of stuff. I would say, keep your resumes and CVs up to date and be nimble, because in this world, I think you guys are going to move around a lot more. A dinosaur like me that, got out of his fellowship and is staying in one place his whole life, it's wonderful. I recommend it to anyone if you can, but it probably will be much less common.
Are you familiar with PNHP, the Physicians for National Health Program, what Dr. Malik is part of?
No.
That's the organization that hosted our internship. He's been organizing you. Thanks for talking, and lots of other folks. Yeah, we've talked to all kinds of people, like people on the Green Mountain Care Board and the CEO of Dartmouth and all kinds of stuff. So anyway, yeah, PNHP is the national organization that's advocating for a national healthcare plan. That's who organized all of this.
Well, I'm glad you decided to get the view of one little fish in addition to all the big ones.
Well, thank you so much for taking the time out of your day to speak with us. We definitely
really appreciated your perspective.
Well, and I wish you all, again, I try not to be too depressing. I think choosing medicine is a great thing, and you guys will have fun. And I have a brother who loves Trump, and it's really tough. I also have another brother who's gay and, clerks for the right judges in DC. But I think, I think there's reason to be positive, and change can come about. It just may not be in the next few years, but I think it will come there. And I would hope that you guys keep, doing the fight and have the bullhorn to get the word out, because more people will be better taken care of, I think, if we do this.
Thank you.
Well, it's great to see a surgeon so supportive of single payer. It's heartening.
Well, yeah, I mean, there may be more than you think out there. Although I do have to say, even in the friggin' Vermont Orthopedic Society, I get these Trump lovers that I just want to throttle sometimes. But, you know, different strokes for different folks. What can I say? I was lucky. My wife opened my eyes to a lot that I might not have seen otherwise.
Great. Thank you. Thanks so
Welcome.
much.
Thank you,
Have
Dr.
a-
Payne. Really
have a
appreciate
good
it.
careers.
Thank
All right.
you.